Hi, I'm Su Kitchen Falls CNC at Sir Charles Gardner Osborne Park Care Group. I'm here to talk to you today about single rooms and reducing the risk of falls and harm from falls for patients who are nursed in these areas. Okay, let's just very quickly have a look at falls management. It's made up of the 6 individual processes that come together to make a falls management program. So we have the governance, which is your policies, your guidelines, your committees, your working groups, all that helps to guide the falls process and best practice throughout the facility. You have the screening and the assessment of patients and the interventions. You have the patient education, which we know is key to preventing falls. And then we have the discharge information and the discharge services. And underpinning all of that is post-fall care. So if the patient does have a fall, we need to ensure that we do this correctly, we follow the guidelines, because if we don't detect that early clinical deterioration, it could have a catastrophic effect for the patient. What's this got to do with single rooms? Well, within your governance, you need to consider single rooms. So what additional screening, what additional interventions you might need to put into place, into policy, into guideline for single rooms. For nurses or for any staff member, any health professional that is screening and assessing the patient, if they're in a single room, the environment needs to be assessed and an intervention appropriately chosen. Patients who are in single rooms, they need education to understand that they're at increased risk of falling, and this is what we would like them to do, this is what we'd like them to consider. So having all of those elements within falls management, single rooms and the environment needs to be considered all the way through. Okay, let's get on to the nitty-gritty. Good design in healthcare facilities can improve health outcomes, reduce your operating costs, it supports patient-centered care, and it promotes staff efficiency by minimizing the distances of travel between frequently used areas. If you think about your workplace now and you think about how far perhaps the sluice room is or how far the medication room is from one end of the ward to the other, then that can give you an idea about whether this is a good design or not a good design. There obviously are standards and legislation of which healthcare facilities need to adhere to when they're being built. And those two links there will assist you in finding out more information if you desire. So how and who decides about single rooms? So it is often within your facility, it would be the executive and the facilities and the planning and the designers, the architects, who would be having that discussion about what did they want that ward or that facility to look like? What is the purpose for it? What's required? There is something called the Australian Design Standards for Healthcare Facilities. Now these are guidelines, they're not necessarily legislation. And I had a look at their website and I had a look at some of their guidelines, and they're worth having a little read. The link here is to one for an acute ward in a tertiary hospital, in an acute hospital. It discusses the layout and it discusses the planning of inpatient units, and it demonstrates that these have evolved significantly, and they find that there's no one particular layout that has been found to be universally superior. And in all cases, the final decision is a response to the physical constraints of the site, local service needs and operational policies, which is as you would expect. These guidelines detail how the configuration should be informed and offers key considerations relating to the appropriate proportion of single rooms. So it actually doesn't recommend that the facility should be all single rooms. It recommends that there should be a mix. They need to consider things like optimal patient observation, efficient staffing arrangements and work practices. Consider the nursing model and the potential allocated resourcing, the location of that unit or of that ward, and the consideration relating to whether it's a metro, regional or rural site. The need to control the entry and exits of the rooms and of the ward to avoid those potential entrapment points. Access to clinical and operational support areas, so those utility rooms, the equipment storage, in relation to bed numbers and also staff travel distances. So there's many key considerations relating to the appropriate proportion of single rooms in a healthcare facility. So what are the advantages for the patient? I'm sure we can all think of many. So patient privacy, particularly in the use of en-suites, and individual control over light levels. There is a better quality of sleep and rest within a single room, and it facilitates greater family participation. It enables patients to follow their religious and their cultural beliefs more easily. There is patient dignity, there's patient confidentiality, so not everybody is hearing all about their medical history. It's nice and quiet, it's peaceful. Infection control purposes, the environment can be more adequately and more ably tailored to the patient and their need. And the nurse can focus on the patient without interruptions, which for the patient is ideal. There are disadvantages of a single room for the patient. So very high risk of depression, and it might promote boredom, promote loneliness, which the boredom can promote poor behaviour. It may promote loneliness, it may promote deconditioning, reduced exercise and reduced movement. It may well promote a hotel culture that came up in research. It may promote a feeling of decreased safety and can promote decreased safety. There is a potential for a delayed response to care and the failure to identify patients at risk of deteriorating and falling because you can't see them as well or as adequately. Patients are unable to support each other, and the patient can feel isolated, insecure and unsafe. There is decreased social interaction, which social interaction, even within hospital when you're feeling unwell, it's absolutely essential for morale and for encouraging well-being. There is decreased visibility for the patient to be able to see people or staff. And it can create an anxiety due to a lack of awareness of surrounding. So many rooms can be very quiet. And it's hard to understand if there's people out there, particularly if they're in an isolation room and they can't see out, they can't see what's going on, they might not be able to see if there is actually staff there or are they by themselves. And you need to think that differing patients have different needs, and that needs to be taken into consideration. Not every patient is suitable for a single room. What are the advantages for staff? Well, as I say, you've got an increased ability to focus without interruptions. If you're in a 4-bedded bay, you might have other patients interrupting you. But in a single room, there's generally just you and the patient, and you can focus. That means greater safety, greater medication safety, greater ability to be for watching for clinical deterioration, and many more reasons. Dignity for the patients. You can tailor your environment to the patient more easily and provides greater flexibility in bed management. And according to the research, it reduces patient transfers and bed moves. There's greater flexibility and space for higher acuity patients, and it can accommodate that additional equipment. Perhaps it is a more appropriate environment for the management of the terminally ill. And it may be a more appropriate environment for patients with behaviours of concern, but that needs assessing. So although you may put a patient with a behaviour problem or in a delirium or in a dementia into a single room, you need to continue to monitor that behaviour, because actually the single room might not be the best option for that patient. What are the disadvantages for staff? Staff generally only know about a fall when a patient falls. There is decreased safety both for the patient but for the staff as well. The team communication can be very challenging, and there may be delayed responses to care. Single rooms create complex environments. It's not just as simple as having a suite of single rooms. The environment becomes more complex, and for those of you that work in areas that have mostly single rooms or all single rooms, you will understand fully what I am saying. There is a reduced capacity to see or hear patients. There's a reduced capacity to monitor them. It promotes deconditioning. There is an increased nursing load with walking distances. And there is a purported decreased job satisfaction. And again, what comes out in the literature is a hotel culture. So what should the layout of a single room be? So when you go into the room, the staff zone should be nearest to the door, and the patient and the visitor zone should be on the other side of the bed. So that means that when you walk in, you should be able to easily access the medications, the emergency call bells, the oxygen, the air, whatever it might need to be from a clinical perspective. You should be able to access that from the side of the bed nearest to the door. To encourage family engagement with care, extra seating should be provided, and there should be a secure storage for belongings. So this is an example here. So you have all of your medical and clinical needs on the right hand side. If you have your medications in the bedside locker, you have access to the bedside locker, and the patient and the visitor side is on the opposite side of the bed. This is a recommended read, this article. So it is an engineering article, and it's full of various algorithms and algebra and lots of things like that. But it looks specifically at the configurations in the design phase and how that can reduce the risk of falls. It considers both the static and the dynamic factors that are affected by a room configuration. And they worked out that how you can reduce the risk of a fall up to 41%. Now, that's just the article in a nutshell, but I really do recommend that you read the article because it provides so much more information. It talks about the surrounding objects and where they should be and how they result in a risk distribution across the entire room. It looks at motion-based evaluation, so looking at how the patient ambulates and the gait properties such as their turning angle and their type of activity, sit to stand, walk, turn, stand to sit. It really is an excellent article to read if you want to understand more about single room environment. So they actually present several different configurations. In this article, in this picture, you can see that the darker the red is, the higher the risk of falling. So in this particular room, this risk of falling, this is what they perceive as a traditional layout. You come in the door and you go to this side. You may have a chair here, patient chair here, and that is a big risk area, not only for patients but for staff. And then as you walk in the room into the ensuite, you have a high risk area right at the entrance, but all the way through the wet area, obviously you have a risk of falling. And then you have sort of areas that are more of a less risk, and areas that are increasing in risk. And then look at the heat map here. So they've reconfigured the room, and you can see that the only risk is over here where it's way out of the way. So it's actually a lower risk than it being here. And even the doorway into the facilities, into the ensuite, it's still a risk, but it's a lower risk. So you can see from different layouts when rooms are being designed how we can actually reduce the risk. When rooms are being designed, when new facilities are being designed, when new wards are being designed, is falls actually taken into account? The reasons why the single rooms may be used, and you'll think of 100 of these, but palliative care, infection control, various bedside procedures, specialing patients, acutely unwell, cognitively impaired, private patients. But please, can I just get you to be aware of bed moves? So there was a study that was completed at Charlie's a few years ago, and it found that with every bed move that was made, either intra-ward or intra-department or ward transfer, it increased the risk of that patient falling by 56%. Now, we move our patients extremely regularly and frequently, and each time we do that, we just keep piling on the risk of the patient falling. So we need to consider the patient, the environment. Is this actually the best thing to do? Is there another option? This study looked at single room usage and allocation decision making in an Australian public hospital. So it found that infection control was the primary reason for patients to be allocated to a single room. Bed moves were very common, resulting in frequent re-evaluation of need. What this study does do is it highlights the complexity of the nursing decision making about patient allocation to single rooms. And there are multiple influences and complications of multiple factors, including occupancy rates, patient family preference, potential funding if it's in a private area, and infection status of the patient, and more. This article does acknowledge that there is a trend towards increasing the proportion of single rooms in hospital new builds. So Fiona Stanley is, I think it's either 83 or 87% of single rooms. So very, very high proportion. But there is actually no Australian studies that investigate the use of single rooms in clinical practice. So from a clinical perspective, other than infection control, are they useful? Do they serve any purpose? Are patients cared better or worse in them? There's no actual study to be looking exactly at clinical practice. So do single rooms increase the risk of falls and harm from falls? So patients with dementia are at increased risk of inpatient falls in single rooms. So one of the first things that often happens is there's a patient who might be impulsive, has a delirium or a dementia, and one of the first things that we do is we move them into a single room by the nurse's station or as close to the nursing station as possible. Where's the noisiest place in the ward? By the nurse's station. We know that these people need peace and quiet, and that really helps to settle them. They may actually be better off staying where they are. If they're in a 4-bedded bay, they have company, they have activity going on, there's things happening, and it reduces the boredom and will help to reduce the impulsiveness, hopefully. There's more to do, more to see, much more interesting. There was one study, it was a small study in South Wales, and there was no change in incidence of falls after moving a hospital with 100% from a multi-bed hospital to a 100% single occupancy bedroom. Actually, this one wasn't, this one was undertaken in America, and I would say that that was a rarity. There are low levels of evidence for patient falls in healthcare design and decision making. As I just explained to you about how that decision making is made, there's very low levels that falls is considered. In a single bed rooms, but not in multiple bedrooms, there is a much higher risk of falls for inpatients that develop delirium than among other inpatients. So again, consider where you put those patients who do have a delirium. They significantly increase the risk of falls and fracture in a hospital design with single rooms compared to a multi-bedded facility. And room sizes should be varied to allow better selection depending on risk. So in many hospitals, you'll find that the rooms are exactly the same size, exactly the same configuration. And actually, the evidence is that this should be varied. Into the design needs to be considered the number and the structure of nurses. So this is very, very important to patient safety. We're with the patients 24 hours a day, and we are key to patient safety. So when designing a hospital or designing a ward or looking at allocation, we need to consider that nurses with greater than 5 years experience are a protective factor against adverse events. So you need to have a good skill mix on your shifts. And then looking at sleep, the WHO guidelines recommend that sound levels of continuous background noise should not exceed 30 decibels, and individual noise events exceeding 45 decibels should be avoided. So in a single room, you'll probably have a very quiet area, potentially, unless you're near the nurse's desk. But do we measure decibels? Do we measure how many we are? Yeah, the Met bell, how loud is that? Does that exceed 45 decibels, particularly at night? So there's things that we can do around sleep in single rooms and sleep in wards that we need to be considering. And there's lots of ways to do that. You can have a monitor that tells you what the decibel level actually is. However, the silence in single rooms can be maddening and not peaceful at all. And if you are in a delirium, it can add to it. It's that complete silence where you can't see out. If you're in isolation, you can't see out, you can't see people, you can't see what's going on. It really may not be helpful. There is very little evidence to support the use of single rooms with older people and with people with neurological disorders. But what is interesting is there has been a shift in patient choice for single rooms. So you can see that into this study, they did the study in 2008 and then they repeated it in 2013. Now there has been a big societal shift between those years. We don't realise it. I mean, that societal shift keeps continuing on, but this study really shows that. So in 2008, 37% of patients expressed a preference for single room accommodation, whereas in 2013, 85% said that they preferred a single room. The majority of patients in 2008, 60%, preferred to eat their meal at their bedside, and that increased to 76% in 2013. The one question that they added into the 2013 survey was about loneliness, and 61% of patients reported that they never felt lonely in a single room. Now, many of us are living alone now, and there are people who choose to live alone, or they're having to live alone through circumstance, and they get used to it. And so they have ways and methods of dealing with that loneliness. So perhaps for a certain generation, loneliness may not be a problem. So what are nurses' experiences about working in hospital wards with single rooms? This is a recommended read, this article, and it is an integrated review, and most of the literature is actually very modern within the last 5 years. Nurses shared multiple concerns about the single rooms and about the varying challenges, and it also acknowledged the patient preference for privacy and space afforded by single rooms. Now, privacy and safety collide at some point. When you have a patient in the shower and they want to be left alone, but you know that they're not safe, that's where privacy and safety collide, and your clinical judgment needs to take over. It's not suitable for everybody, particularly the elderly, was what these nurses' work experiences found. And they were very, very concerned over the loss of the ability to eyeball patients easily. And a quote taken from the article is, "You have to adjust your nursing practice just to make sure that everybody is seen, and you keep an eye on them the whole time. You have to physically go into each and everybody's room or stop and have a look at them." So how do we provide care to reduce the risk of falling? So what can reduce the risk? And these are the key things that you could do. These are in the literature as the key, most effective, most beneficial at reducing the risk of falls and harm from falls in single rooms. Number one, the multifactorial falls risk assessment and intervention from the team. This is from everybody, but this must be done. And not only the risk factors of the patient, but also the environment needs to be considered and mitigation implemented. Nursing education on falls. Nurses need to know everything there is to know about falls so that they can understand fully about the risk assessments and about the interventions required. So frequent visualization, there is no other way to do it. If you have a ward of single rooms, the only way to do this is frequent visualization. So an example may be you have at the beginning of your shift, there's a huddle and you pick the 5 most high-risk patients. These are put up on the board and the whole team does rounds on these frequently. So they visualize them frequently. And then everyone needs to consider the environment. So when the medical staff are doing their rounds, they need to be looking at the environment as well. Is this a safe environment for their patient? Don't forget the consultant is the one person who is the final accountable person for his patient's safety. Ensure the curtains do not block being able to see the patient as staff walk past. There appears to have been a habit where, other than for personal care, the curtains are left around the patient. This means that you can't see the patient, and this is where privacy and safety collides. And if the patient doesn't need privacy because there's no personal care going on, the curtains should be back and you should be able to fully see the patient safe so that they are safe and visible. Consider workflow allocation. So consider walking distances. So perhaps not to allocate patients from one end of the ward and then a couple of patients from the other end of the ward to one person. Consider your allocation. The walking distances also increase the risk of adverse events and of patients falling. It doesn't promote patient safety within a ward area. It also, when you allocate correctly, you help to prevent that sense of isolation. So working with only single rooms really can present a feeling of isolation. And as nurses, we don't like that. We're part of a team. We want to work as part of a team. So it's important that you do that. So careful planning, maintain and strengthen that teamwork. So there are several resources, but a checklist before leaving the room, which I'll go through, giving the patient that information, making them understand that they're less visible, that we'll check on them regularly, but they can help us as well, although that is not the prime function of the patient. The patient is there to get better. So let them know that they are at an increased risk of a fall in a single room. Give them some exercises. Try and reduce that deconditioning. It doesn't need to be run a marathon on a treadmill. Simple bed exercises, arm exercises, chair exercises, but they also help to relieve the boredom. So some of the I know that you all have resources, okay, but some of the resources that are available. So we're currently developing patient information at Osborne Park. Once we've done that, I will, through my Falls networks, let everybody know, because we're always willing to share. Hospitals have got varying resources, I know, because we've collaborated on that. And for Charlie's, we have resources on our Falls website. So this is our Falls website, and on the left you can see that there is a web page dedicated to single rooms, isolation and COVID and falls. There's varying different information on there, but some of these resources include a leaflet for intentional patient rounding, really worth a read and really worth a consideration. Then we have the isolation and falls checklist. So before you leave the room, you need to have checked that the following is in place. That's going to increase your patient's safety if you do this. There is information for clinicians using safety huddles during COVID-19, but you can just remove the COVID-19 bit and just use the safety huddles. So pre and post fall huddles, they do work if they're done correctly, and this information will help you to develop those huddles and implement them. And then there's the World Health Organization, which is information for self-management after a COVID-19 related illness, but to be honest, a lot of the information will help anybody who is in self-management for rehabilitation. If as a nurse that you're unsure how to do mobility assessments, so if your patient's in a single room and you want to get them up to the bathroom but you're not sure whether they're able to, and the physio hasn't yet been to see them or isn't able to, then this is a very simple guide to step by step to manage that assessment. So is the patient able to follow simple commands and gestures? Yes. Can the patient change position or move around in the bed? Yes. Can the patient safely sit on the edge of the bed? Yes. Can they then safely stand upright? Yes. Can they lift one foot off the floor and then the other? Yes. You're ready to move. So that patient has enough strength that they could certainly walk a short distance. Do it with 2 people, not with 1. And this assessment really should help to stop that deconditioning, give the nurses confidence to complete an assessment. So my take homes for you. If you get asked to help with design, please do so. Really important. I'm not sure whether nurses or health professionals that are actually working at the bedside get any opportunity to assist with design. So if you can influence that, please do so. The risk of falling is increased in a single room, particularly in those with dementia, and the risk of an injury from a fall is increased. For nursing, the multifactorial falls risk assessment and intervention is the key to prevention and reducing the risk. Consider intentional rounding and use the advice and the resources that are available. Thank you.